Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Mr. Gonzalez. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning. Good morning. Please be seated. May I know your health problem? Well, doctor, I am a patient with end-stage chronic obstructive pulmonary disease, and I had a tracheostomy tube placement 3 months ago. I underwent treatment for acute exacerbation of the disease. Now I am residing in an extended care facility with a capped tracheostomy tube. I need persistent oxygen administration, and there has been some tenderness with the tracheostomy tube and difficulty in swallowing. I want it to be removed. Is there any airway issues while sleeping or uncapping the tube? No, doctor. What's your age? 59, doctor. Do you drink or smoke? I smoke, and I was addicted to alcohol, but I have stopped it recently. Do you have any other disease history or treatments? Well, other than chronic obstructive pulmonary disease, I had hypercarbic hypoxemia, coronary artery disease, myocardial infarction, and liver cirrhosis secondary to alcohol use. Okay, have you faced any surgery previously? Yes, doctor. Tonsillectomy, adenoidectomy, cholecystectomy, appendectomy, hernia repair, and tracheostomy. Okay, brief me about any diseases that your family members have. Well, my family members have heart disease, coronary artery disease, hypertension, diabetes mellitus, and cerebrovascular accident. Right. What medications are you taking now? Prevacid, folic acid, aspirin, morphine sulfate, Pulmicort, Risperdal, Coles, clonazepam, Lotrazone, Ronaxol, Ambien, Zolpidem tartrate, Simethicone, Robitussin, and Prednisone. Are you allergic to any medication? Yes, I am allergic to nitroglycerin. Well, physical investigation shows that blood pressure is 170/78, pulse rate is 96, and temperature is 98.6. There is a stable appearing tracheostomy tube site, and the stoma appears to be without signs of infection. The previous incision was vertical in nature, and there is no hypertrophic scar formation. No adenopathy noted. No stridor noted. Your diagnosis reports show you have end-stage chronic obstructive pulmonary disease with a history of respiratory failure requiring mechanical ventilatory support with tracheostomy tube placement. You have difficulty in tolerating tracheostomy tubes secondary to swallow discomfort and neck irritation with no further need for tracheostomy tube. You have a history of coronary artery disease, myocardial infarction, and cirrhosis of liver. I would recommend a limited bronchoscopy and then fiberoptic laryngoscopy, but you may have trouble with the area healing or scarring, or you may have an emergent airway situation with the tube gone. That's okay with me, doctor. Anyway, I want to get the tube removed. Okay, that's good.
Extract 2, questions 13 to 24. You hear a doctor in an emergency department talking to a patient called Gail Kennedy. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mrs. Kennedy?
Yes.
I'm Dr. Jarvis.
Hello.
Sorry to keep you waiting.
Okay.
Now, can you tell me what's brought you here today?
Well, I got back from holiday 2 weeks ago, and I've been feeling awful ever since. It was a long-haul flight because we'd been to South America, and when I got back I felt awful. I thought it must be jet lag, but brutal. Much worse than I remember having before. Anyway, I thought I'd get over it, but it actually got worse. After a few days, I was getting bad chills and non-stop shivering and achy muscles. I just felt lousy. I mean, normally I'm pretty healthy. I don't get a lot of illnesses. So I started to worry. I thought maybe I got meningitis.
Right.
So I rang the doctor. When I told him where I'd been, he said I should come in and see him because it might be malaria. So I said, well, it can't be because I've been taking Malarone. I started on that 2 weeks before going away. I tried, Lariam a few years ago, but it gave me really odd dreams, so I didn't want to take that again. Anyway, the doctor said some sorts of malaria are resistant to these drugs, and I know I did get a few bites when we were there. He gave me some pills to take for 3 days, just in case it was malaria.
Right. Can you tell me what they were?
Oh, art something?
Artesunate.
That's right. And something else. Hang on, I've got the box here. Mefloquine.
Okay.
So I went home and I took the pills, but I didn't feel any better. In fact, I got worse. I felt really weak and I was sweating buckets, just dripping with it. I finished the pills yesterday morning. Since then, I've been really bad. I haven't been able to keep anything down. I was throwing up all day yesterday and had the most splitting headache. I've never had anything like it. So I rang the doctor again, and he said the blood test had come back negative. But if I wasn't feeling better today, I should come into the emergency department and get some more tests done.
Right. Well, I'll just do a brief examination.
Okay.
Okay, so your skin's a good colour, I can't see any sign of jaundice, and your breathing's sounding pretty good. You haven't had any episodes of breathlessness, have you?
No. But yesterday, my heart was really racing.
Yes, there is some evidence of that now.
And, something else. All this week, I felt as if there was something scratchy in my eyes, like sand or something, and they feel really dry.
I see. And have you had any abdominal discomforts?
Well, there's no pain, but I don't have any appetite. I can't really keep anything down, like I said.
Right. Now, apart from taking the anti-malarials, did you have any vaccinations before you went away?
Yeah, I had all the injections. Typhoid and what else? Not yellow fever, because I'd already had that before. But I did have one for hepatitis A.
Yeah.
And they were fine. I don't usually have any problems with things like that. Then, while we were away, I did get cold sores all over me upper lip. I've had them before, and I'd got some over-the-counter stuff for them, so I just used that.
Right.
Apart from that, I was fine during the holiday. I'm normally very healthy. I did have breast cancer a few years ago. That was in 2011. I had a lumpectomy, so I was taking tamoxifen for 5 years. But I don't have to take it now.
Okay. So it's possible that this might be a reaction to certain drugs, but we'll need to do some more tests first.
In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear two doctors discussing a patient.
Oh, Dr. Khan, have you got a moment? I wanted to talk to you about polypeptide.
Sure, Dr. Jones.
Polly is a 6-year-old girl with a medical history of asthma and eczema who was admitted yesterday for an asthma exacerbation. She presented with shortness of breath and cough after visiting her grandparents, who are smokers. She responded well to albuterol and prednisolone in the emergency department, but was admitted due to persistent hypoxia in room air. She was also given a recent dose of acetaminophen because of fever. Her current temperature is 39.7 degrees Celsius.
How is she on auscultation?
There are significant audible expiratory wheezes throughout the left lung and in the right upper regions. Her breathing sounds are diminished and there is an absence of wheezes towards the right base.
Possible bacterial pneumonia?
Dr. Jones, that's what I was thinking. I'm sending her for a full range of tests to confirm. Thank you, Dr. Khan.
You hear a dietitian talking to a patient.
There are reasons the doctor talked to you about being on a diet that's low in fat.
I know, but I like salami, cheese and chips. A meal's not a meal without bread and butter.
I can understand that it's hard for you. I myself have tried to eliminate nearly all the fat from my own diet, and it is difficult to give up the things we love so much.
What foods have you had to give up?
Well, ice cream was my favourite. I used to have a bowl of it almost every night. But there's been others, butter, sausages. Look, no one's saying that you can't eat fatty foods occasionally, but you really do need to try and reduce your overall fat intake if you want to start feeling better. Here, let's look at a possible meal plan. It'll give you a better idea of what I'm talking about.
You hear a professor of emergency medicine giving a presentation to a group of trainee doctors.
European wasps feed on meat and meat products, such as dog food and barbecue scraps. They also like to scavenge sweet food and drinks and steal honey from beehives. Their stings are not barbed like bee stings. This means a single wasp can sting repeatedly. The toxins in the sting will cause a powerful reaction, and in some people, an allergic reaction. Because they are attracted to food, many wasp stings are in or around the mouth. These are the most dangerous places for a sting, as swelling can result. Minor reactions include painful swellings on the lips, while in severe cases, there can be a blockage of the trachea due to swelling, and in the most severe cases, this can even lead to death.
You hear a GP talking to a regular patient who has been having kidney problems.
Hello, Mr. Hartley. Come and sit down. I gather you've been having more trouble since I last saw you.
Yes, that's right. I kept vomiting and feeling dreadful. I can't keep on like this.
It looks as though the next step will be to get you to hospital to start further treatment. I think you're going to need peritoneal dialysis treatment.
What's that, Doctor?
It means putting a tube into the abdomen and then washing fluid in and out to keep the toxic substances in the blood down. It's not uncomfortable, and you'll be taught to do this yourself for when you get home. With this method of dialysis, you can walk about and live a reasonably normal life.
Well, will I have to use this for the rest of my life?
Well, we will also take a specimen of your blood and put you in the computer database for a kidney transplant. If a suitable kidney becomes available, you may be able to undergo a kidney transplant operation. So you see, there are several ways of helping you. We'll just have to see how you get on.
You hear a physiotherapist in a hospital talking with John, a new patient.
Okay, John, now that we've established you're not going to be playing sport, here's what you're going to need to do for the next 2 to 4 weeks.
Okay.
First of all, you're going to have to wear a neck brace. You can get one in the shop down the ground floor.
Do I wear that at night, like when I'm sleeping?
Well, you can, but you don't have to.
Okay.
One thing that will help with the pain is an ice pack for 10 to 20 minutes, followed by a nice warm shower.
Okay. I'll still probably be working a bit. We don't have a shower there.
If you're at work, you can just use a warm cloth instead. Another really good thing to do is neck and back stretches. We can go through them now if you like.
Okay, great.
You hear a specialist physician and a nurse discussing a patient's treatment.
Nurse, hello. I'm wondering if you can help me. I've just been going over the charts for Mr. Chu in bed 34, and I'm wondering why I wasn't told that his blood pressure medications were being held over the past few days.
Oh, hi, Dr. Greisman. Right, I'm not sure. I didn't even know that had happened. Let me look into it and get back to you.
There's no need for that. I've been sitting here for 20 minutes looking at the blood pressures and medications that have been given to the patient, and it simply doesn't make any sense.
Well, I really don't know, Doctor. I've literally taken care of this patient for 4 hours. I can discuss it with the nursing director, though, if you like.
No, that isn't necessary. Thank you, nurse.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
In this part of the test, you will hear a lecture based on the subject of chronic obstructive pulmonary disease.
You now have 90 seconds to read questions 31 to 36.
Chronic obstructive pulmonary disease, COPD, is a growing global epidemic that is significant in both developed and developing countries. Morbidity and mortality from COPD will rise as populations age. Furthermore, as the mortality from cardiovascular and infectious diseases falls, the occurrence of COPD will become more common in society. This is supported by the current trend, which indicates that more people are dying from COPD each year. In addition, COPD is associated with several other diseases such as osteoporosis, diabetes, glaucoma, and sleep disorders. In Australia, almost 1 in 5 people over 40 have COPD, and it's the 4th most common cause of death in men and the 6th most common cause of death in women. Smokers, or past smokers, are those who are at major risk of getting COPD, and most people with COPD have smoked at least 10 to 20 cigarettes per day for 20 or more years before experiencing any symptoms. As a result, COPD is typically not diagnosed until the 5th decade of life, meaning in people aged 40 to 49 years. So who can get COPD? Well, whereas cigarette smoking is the commonest form of COPD in developed countries, it's also seen in non-smokers, particularly in developing countries, which may be due to the other causes of COPD, which include occupational dust and fume exposure, exposure to outdoor and indoor air pollution, including tobacco smoke, poorly ventilated living environments where pollution is present, often due to the use of solid fuels for cooking and heating, individuals who have a genetic predisposition to COPD, or individuals with a history of recurrent childhood respiratory infections. In addition, some people with COPD have worked or lived in places that were very dusty or smoky for many years. COPD is primarily characterised by the presence of airflow limitation resulting from inflammation and remodelling of small airways, and is often associated with emphysema. The common symptoms are repeated coughing, feeling puffed or shortness of breath when doing things like climbing stairs, walking up a hill, or even having a shower, a build-up of phlegm in the lungs, or chest tightness. With COPD, your lungs become larger than normal, so the breathing muscles around the outside of the lungs, such as the diaphragm and chest wall muscles, become stretched and have to work harder. This means that there's more effort involved in breathing, and it makes you feel breathless. It's increasingly recognised that COPD extends beyond the lung, and that many patients have several systemic manifestations that can further reduce quality of life. So how is COPD diagnosed? COPD is tested with a simple breathing test using a spirometer, which records the amount of and the rate of air that you breathe in and out over a period of time. It's essential the procedure is carefully and clearly explained, and to actively motivate the patient to perform at their maximum level. The volume and flow parameters measured are defined in terms of maximum effort and maximum exhaled volume. It's preferable for the patient to sit upright in a chair, as this is the most stable position should the patient experience dizziness during the test. The key steps are as follows. First, breathe in fully, and the lungs must be absolutely full. Seal the lips around the mouthpiece and blast the air out as fast and as far as possible until the lungs are completely empty. Repeat the test until 3 acceptable results are obtained, up to a maximum of 8 efforts. The results can measure the presence and severity of COPD. The severity of COPD is categorised into 3 levels. Mild, where the breathing capacity is 60 to 80% of normal. Sufferers feel a little out of breath if they work hard or walk rapidly, especially on hills and stairs. Moderate, where breathing capacity is 40 to 60% of normal. Sufferers feel out of breath if they walk rapidly and they may have trouble doing physical activities. Severe, where breathing capacity is less than 40% of normal. Sufferers probably can't work or do household chores and have difficulty in walking upstairs or across the room.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a junior doctor called Graham Holder giving a presentation on the subject of hand transplants. You now have 90 seconds to read questions 37 to 42.
Good morning, my name's Graham Holder. I'm a junior doctor here at the hospital. The subject of my presentation today is hand transplants. I'm not a specialist in this area and I have no direct experience of it, but I've always found it fascinating and I'd like to share my interest in it with you. So, first of all, what is a hand transplant and why is it better than prostheses? Well, it's a type of CTA, that's a composite tissue allotransplantation, in which skin, fat, muscle and nerve bone are all transferred from one person to another. To date, it's largely been used to treat patients with both functional and aesthetic deficits that can't be dealt with by conventional methods, but this is changing. The mainstay of treatment for amputated limbs has long been prostheses, but patients often reject them because they only provide limited mobility and function, and they can be uncomfortable. In theory at least, transplanting a complete part should give much better results than even the most advanced prosthetic technology. So, more and more upper limb transplants are being performed around the world every year, and this is largely thanks to new and more powerful immune suppressive drugs. The strategies in use have been derived from the experience of transplanting organs, especially kidneys, and this has also informed the choice of drugs. Slightly higher amounts of immune suppression are used with a potent induction, followed by a low-dose maintenance regime. This regime can be supplemented by short courses of intensive therapy to overcome any episode of acute rejection. The survival rate of both patients and grafts under this regimen outperforms that for all other transplants. That's actually pretty impressive. At least one episode of rejection is recorded in 90% of cases, however, despite the immune suppressive protocol, and this is much higher than with kidney transplants. One reason for this is that hand transplantation represents a visible graft. That means you can make an immediate diagnosis of rejection based on minor changes in skin appearance, even though this has to be confirmed by a biopsy. If patients adhere to the regime, however, rejection is generally reversible. One of the challenges of hand transplantation is to achieve the delicate balance that prevents rejection whilst at the same time protecting patients from the direct toxicity of the medicaments. But this seems to be working, and infection is actually the commonest complication. So, what happens during a hand transplant operation? It's a 6-hour procedure which involves 2 separate surgical teams, one removing the hand from the donor and the other working with the recipient. Bones are joined with titanium plates and screws. As with other bone grafts, they should eventually heal together, but the plates are left in to ensure stability. Surgeons then connect key muscles and tendons before tiny blood vessels are connected using surgical microscopes. 3 major nerves are then attached, followed by large and small veins. Once blood is circulating, the recipient begins to feel the new hand. A recent case attracted a lot of interest in the UK. It was a bilateral transplant for a man who'd lost both hands in an accident at work. Now, bilateral transplants aren't so uncommon, but what made the case particularly noteworthy was the fact that he still had both his thumbs, but not the rest of his hands. So it wasn't a transplant performed at the wrist, as is usually the case, but in the substance of both hands. Nonetheless, immediately afterwards, he managed to gain some movement in his donor hands and has since improved dramatically. Indeed, just 9 months after the procedure, he was able to write a thank you letter to the surgeon. His recovery experience mirrors that of most transplant patients. The incredible thing about him is the speed at which he's gained that functionality. So, what about donors? One of the challenges of hand transplantation is that the hands not only have to fit immunologically, they also have to look right because they're going to be on view, an issue that doesn't arise with internal organs. That makes the job of finding an appropriate donor even harder. In any case, because hand transplantation is rather unusual, people have been slow to donate, and there have been occasions when surgeons had to ask for a donation when somebody's offered other organs, but not specifically the hands, and that's a really difficult thing to negotiate with next of kin at the time of death. The hand transplant program is now established and it's becoming mature. It'd be nice to think that hand transplants could become as routine as kidney transplants. Setting up a donor network is the next goal.
That is the end of Part C.